Well, good morning everyone, and welcome to the official IAS 2015 press briefing on HIV hepatitis co-infection, including those joining us online via the live streaming of this briefing. My name is Linda-Gail Becker. I'm the Deputy Director of the Desmund Tutu HIV Centre in Cape Town and currently the President-elect of the International AIDS Society. So again, warm welcome to everyone. We of course know that the HIV epidemic does not exist in a vacuum. The story of HIV is very much the story of other serious illnesses, including other infections, and of course including viral hepatitis. They often accompany HIV either because they are transmitted in similar ways or because HIV-positive individuals with weakened immune systems are more susceptible to other diseases and infections. Expanding global access to treatment and prevention for serious co-infections is a critical but often overlooked component of efforts to reduce the toll of the HIV epidemic. The past few decades of HIV research on antiretrovirals have had a significant impact on the development of research into hepatitis drugs. And of course, we've all recently heard of the really revolutionary progress we've made in the last 2 years. We've seen the introduction of the non-interferon treatments and other breakthrough drugs that can now actually not only control but cure hepatitis C in just a matter of weeks. So this really has changed the field in the most extraordinary way. With the availability of these new drugs comes, of course, the issue of access. And inequity and the ability of all regions of the world to actually benefit from them. And it's no exaggeration to say that we are, again, revisiting the debate that we, within the HIV field, faced almost 2 decades ago. The notion of putting 15 million people onto HIV treatment by 2015, somewhat of a pipe dream then, has been realized. And of course, this is our aspirational dream, that we could realize that same kind of success in the field of hepatitis. So we'd like to discuss today the state of play in HIV hepatitis co-infection with an eye towards recent debates around the science and the access to new treatments and how, of course, they relate to these co-infections. I want to say at that point that it's because of this that the International AIDS Society has taken on the task of really understanding this interaction, and now co-infections is a priority within the International AIDS Society. I'm also pleased to say that on our panel today are the 2 GC members who actually head up the priority, and we'll be introducing them in fact just at this moment. So our first speaker is Jurgen Rockstroh, Professor of Medicine and Head of the HIV outpatient clinic at the University of Bonn in Germany. Jurgen was a lead investigator on the recently released Phase 3 Sea-Edge study in people with HIV and hepatitis C co-infection, and is a noted leader in this field of research. Jurgen will talk briefly today about where we've come scientifically on HIV hepatitis co-infection and also set the scene for the future challenges that we will be facing in the next few years. So, Jurgen, over to you.
Yeah, so let me just remind you all that due to shared transmission pathways, there's a considerable overlap of HIV and hepatitis C co-infection. We estimate that, at least according to the new figures, around 4 million worldwide should have hepatitis C on top of their HIV infection. Clearly, we also understand, and that's clearly one of the challenges for the future, that we need better surveillance programs. Many countries cannot describe their actual infection rate. And clearly, if everyone is curable, we have to know who it is so that we can identify therapies to people. That would include that we also need better diagnostic methods, which much easier and cheaper allow the diagnosis of replicating hepatitis C, which would then enable corresponding treatment. I think the hallmark of hepatitis C and HIV is really, unfortunately, the much faster fibrosis progression. And the early years of co-infection were determined by the increased toll of liver morbidity and mortality. People started to die from liver disease once HIV became controllable. And in the realization of that, there has been a real struggle with the community to find optimized treatment regimens, because unfortunately, co-infected patients responded much less favorably to interferon-based regimens when they were combined with ribavirin than mono-infected patients. In the most common genotype, so hepatitis C exists in different genotypes, genotype 1, which accounts probably for 2/3 of the infections, the overall cure rate was probably not higher than 30%, really limiting the overall treatment access. Also, the high burden of adverse events further limited the widespread use, and it was unfortunate at least that only 10% of the North American, probably around 15-20% of the European patients ever received hepatitis C treatment in the setting of HIV and hepatitis C because of the perceived low response rates and the very high burden of adverse events. Now, within the last 2 years, this has all dramatically changed. And in the hepatitis oral session yesterday, it was really quite amazing to see that we had 4 different drug combinations being presented, which all came out without interferon, and most likely also without ribavirin, demonstrating cure rates on average above 95%. And that included treatment-experienced patients, so those who had failed with interferon and ribavirin, included those patients who had cirrhosis. And that really is a tremendous breakthrough because it really indicates several things. First, it indicates that there's no longer separation between co and mono-infected patients. They actually respond just the same way. So there's really no barrier anymore to say lower response rates would prevent treatment uptake. And in the setting of a still faster fibrosis progression and a higher risk of hepatic decompensation, we would emphasize that there remains a prioritization in treating HIV and hepatitis C infected patients. And indeed, when you go to many programs which are established worldwide, for example, Brazil and other countries, all patients with HIV and hepatitis C actually have access to treatment independent of fibrosis. And I think one thing I want to highlight from that oral hepatitis session, when we're talking about scientific advances, I think one of the important issues also for those people who at the end pay the drugs is to understand what is the consequence of achieving a cure, which we call SVR, sustained virologic response, which is a negative hepatitis C RNA 12 to 24 weeks after stopping therapy. So what does that mean for someone? And the most, I think, important thing is that it does not only decrease the risk of liver disease, but it also improves overall survival, really indicating that hepatitis is not only something which affects the liver, but ongoing viral infection causes inflammation that has an impact on other organs. I think that's the one message. And the most important message for me yesterday from that session was that actually the Spanish colleague Santi Moreno showed that if you achieve fibrosis reduction under successful hepatitis C therapy on top of your SVR, that has the biggest impact on improving survival, which means if you have very advanced cirrhosis, you may not really have a regression to earlier fibrosis stages, and your benefit on survival may be limited. Whereas if you get treated early enough, you have the full benefit of therapy. It's a real strong argument for earlier treatment. And I think what we're currently seeing, and I'm sure Tracy is going to touch upon that as well, is that access due to cost constraints is limited to advanced fibrosis stages. But are they going to benefit the same amount as early treatment? Regardless of also mentioning that obviously earlier initiation of therapy is associated with shorter treatment durations and less costs altogether and easier application of therapy. So I think what the challenge remains in the future is to convince payers that really everyone should be treated with co-infection, regardless of fibrosis stage, and come up with a public health approach which allows a very simple pangenotypic regimen, which is not longer than 12 weeks, achieves cure of more than 95%, and can be done on the basis of a very simple dry blood spot diagnostic tests, which shows indicated or replicated hepatitis C, and then allow global eradication.
Thanks, Jurgen. And so I see immediate parallels here. Of course, this conference, I think, will be also remembered because of the release of the START study and this notion with Temprano that actually we need to start treatment right away within HIV infection. What we're hearing is indeed there are parallels here with hepatitis C as well. I was struck, Jurgen, yesterday in the plenary that was delivered on hepatitis C treatment, just that sort of quite rapid improvement in quality of life. So not only are you improving outcomes and morbidity, but actually, importantly, people start to feel better, so much better, so much sooner. So I think, this is such an exciting time and very important that we're thinking about it here at our HIV conference as well. So our next panelist is Tracy Swan. Welcome, Tracy. She is the Hepatitis HIV Project Director on the Treatment Action Group in the United States. She'll talk today about the many considerations that we have to think about, and in particular, critical to this, cash is king, the issue of global health at present, access to drug that, how do we actually access these drugs that cure hepatitis C? And I think we're hoping, Tracy, you'll provide some insight on the implications of today's cures for people co-infected with HIV and what that sort of interaction with cost means for people around the world. Tracy.
Thank you. If you were looking at this sheerly from a financial perspective and eliminating all thought of the human right to health, you could simply say it's not a good investment to spend money on delivering antiretroviral therapy to people and just ignoring their liver disease. People who are co-infected, especially with hepatitis C, sometimes have a more difficult time tolerating their antiretroviral therapy, poorer quality of life, and they're vulnerable to a range of systemic health problems, some of which overlap with problems associated with HIV. So just from an investment perspective, it makes perfect sense to make treatment available to all HIV-positive people who are co-infected with hepatitis C. One of the things that people don't think about, I think the high cost of direct-acting antivirals has overshadowed this, but in places where HIV treatment is based on the WHO recommended antiretroviral regimens, it really limits some of your options for DAA-based treatment, and that we're going to have to really consider how to scale up and make antiretrovirals that can be used with hepatitis C treatment available. This is challenging financially, it makes procurement challenging, it makes several things challenging, including talking to someone who really trusts their HIV regimen, has been doing very well on it for a long time, and saying, you're going to need to switch to something else if you want your hepatitis C cured. And I think that's a sort of hidden expense and complication. It's not insurmountable, but it's important to consider. I actually feel quite hopeful with the advent of all the generic DAAs that are coming out. I think it will create the opportunity to treat co-infected people, and there already is a healthcare system that can deliver treatment to people living with HIV. I think the big challenge is how we're going to leverage that for the much bigger epidemic, also of people who don't have HIV. Because if we try to stop co-infection in one population and leave another entire large group with viral hepatitis, viruses don't really recognize barriers like, you know, this person has HIV and they have access to treatment, this one doesn't. It also challenges us because there are really several different hepatitis C epidemics. There's the one among people who inject drugs, and that can be quite challenging to successfully deliver antiretroviral care and treatment, let alone HIV treatment, harm reduction, etc. There is the one among people who are exposed through unsafe medical injections, and there's the epidemic among HIV-positive men who have sex with men. We're going to need different messages and different approaches to reach all of them. But the other really important thing to think about is this is a cure. I know people who endured really harsh side effects from interferon and said this is nothing because I can be cured. I've been living with HIV for 2 decades, and there was no cure for that right now, and I'm willing to do whatever I can to be cured of something. So as complicated as it might be, the idea for both patients and their medical providers, how exciting to be able to cure people. It's a wonderful thing. So I think we need to hold on to the level of optimism about what these drugs can bring to people, as well as working to continue to make them more affordable.
Thanks, Tracy. And you know, we've just come from a plenary that highlighted the really drastic situation in Eastern Europe and Central Asia, and just what's happening there. And you know, it focuses our thinking also for those parts of the world that are perhaps more developing and really in need of these drugs. And so we'll turn to our next speaker, who is going to bring a developing world perspective. Anchalee Avihingsonon is the head of the medical department of the HIV Netherlands Australia Research Collaboration. She's led and coordinated over 40 clinical trials investigating various aspects of HIV. She obtained both Thai government and international funding to look at pharmacokinetics of low-dose antiretrovirals and studies of tuberculosis, Hep C, Hep B, and HIV renal disease. Anchalee will talk to the major issues around co-infection that impact Thailand and the region in Southeast Asia. Thanks, Anchalee.
Thank you. So in Thailand and in Southeast Asia, it's not just hepatitis C mainly. We also have the prevalence of hepatitis B, which is I think nowhere in the world that have greatly impacted by hepatitis B compared to in Asia compared to other countries. So right now we have both HIV, hepatitis B, and hepatitis C. But the problem is the knowledge and awareness of the patient, of the healthcare system, and also the political will is still lag behind for screening the case, and also for the scaling up the treatment for the patient. And in addition with that, the surveillance of the system of the hepatitis B or hepatitis C, majority of the country we don't have that system in place yet. And again, we right now we do more for HIV, but in terms of the low awareness of hepatitis B and hepatitis C, resulting in the low screening rate, and also this impact to the problem whether the government can see the problem and the burden of the disease. When we look at the prevalence of hepatitis B co-infection, still around 10% in this area. And for hepatitis C, we just look at the survey in Thailand, it's around 6%. This is in HIV co-infection. So especially among the patients with high-risk population of hepatitis C, the drug user population, we don't have any data on that. And for drug user population, they are illegal for many settings in Asia. So it's very difficult for them to access to treatment and care. So we have to develop some special approach for that. So in summary for this area, it's not just the economic constraint, but also the advocacy and training constraint. And not just only HIV co-infection, but mainly non-HIV co-infection, especially hepatitis B. Although we have hepatitis B vaccine in place, but how about the patients who are currently infected with hepatitis B? So it is a major challenges in this area. And combined with high prevalence of Hep B, HIV, and also with Hep C, so that the liver disease burden will be greatly influence on this population. So we need to do more, and many challenges for this area, and not just in Asia, and for African countries in terms of the preventing mother-to-child transmission to prevent next generation. So for all of these issues, it will be at rate for this hepatitis B and HIV co-infection workshop in this afternoon.
Well, thanks, Anchalee. And so again, we are in the beautiful city of Vancouver for this conference, right here in British Columbia in Canada. And so bringing us back to the local level, the co-chair of the co-infection priority group within the International AIDS Society is Marina Klein. Welcome, Marina. She's an associate professor of medicine at McGill University in Montreal, Canada, and works in the division of infectious diseases and chronic viral illnesses. She too is a prominent researcher in the clinical and epidemiological aspects of HIV and Hep C, and has been a principal investigator in several clinical trials of HIV, HCV co-infection. She currently leads the Canadian Institutes of Health Research-funded prospective cohort study of over 1,000 co-infected patients to study the interaction of these chronic viral infections. So Marina, we'd love to hear your comments on this problem from a local perspective.
Thanks very much, Linda. I think, first of all, to say I've now led the Canadian co-infection cohort study for almost 15 years, which has really given us a very broad perspective on what the situation is in Canada across the country. We recruit patients from 18 sites, and it represents approximately 25% of the co-infected persons in care, and we now follow almost 1,500 patients. And it was recently, happy to say this, recently refunded by the Canadian Institutes of Health Research for the next 7 years. And so what this cohort has been able to demonstrate to us is really, number one, it echoes some of the concerns that people have raised today, that end-stage liver disease has now really become the predominant cause of morbidity and death in our population. In the early days of the cohort, we would see many more people die from HIV-related illness and AIDS. As antiretroviral therapy became much more used within the cohort, this has declined substantially, and now end-stage liver disease has become the major cause of death. It's followed closely, though, by deaths from overdose. And so I think we can't forget that these two things are so intimately entwined. In Canada, the epidemic is largely driven by people who inject drugs. And in our cohort, over 85% of people have had exposure to injection drug use in their lifetime, and 30% of people continue to inject. The other thing it shows us is that really this is a question of concentrated epidemics. I think one of the things we've observed in the last couple of years is this incredible increase in infections in Western Canada, and particularly Saskatchewan and Manitoba, where largely driven by injection drug use in Aboriginal communities, there's an enormous burden of both HIV and hepatitis C. And it's quite frightening, really, to see how advanced people are presenting with their illness, how little opportunity they've had to access care, and how rarely they've been treated for hepatitis C. It's an extreme need and one of our major focuses going forward. In fact, we had a session organized during the IS conference this time on concentrated epidemics, because if we look at developed countries, we can't forget that there's still ongoing transmissions that are very important, that no matter how good our drugs are, it's not going to be the only response to this epidemic. We really need to address what's going on in these communities to prevent new infections, because reinfection is a real concern when we talk about using these treatments, particularly these treatments which are costing a tremendous amount to the healthcare system. We're already seeing many jurisdictions restrict treatment to once-in-a-lifetime treatment. So how can we do this when we know that reinfection rates are going to be a real concern? If we don't tie that to harm reduction strategies, which we know work and work very well. Canada's been a leader in harm reduction, particularly in the West Coast here, but we still have a patchwork of services that are available to people, especially in rural areas, on reserves, and in Aboriginal communities. This, I think, is the major focus, and I think when we have to look at this, we have to really examine our models of care. How can we improve models of care that can meet the needs of the different types of people who are infected? And second, how do we actually unify and create a real public health approach to this epidemic as opposed to a medical approach to this epidemic? Because treating our way out is not going to be the answer. And if you look across Canada, there's a tremendous patchwork of reimbursement programs for hepatitis C treatment, which really limits access to the vast majority of people who need care. And so our focus really over the next 7 years will be to examine how we can improve the models of care and delivery, target people who are most in need of treatment, and get governments to really embrace the need for a public health approach to this epidemic so that we can see in our lifetime elimination of hepatitis C.
Great, thanks Marina. So, you know, I think Vancouver does need to be congratulated on an extraordinary program. I was most impressed to hear about it yesterday, and you know, one is hopeful that that can be emulated and expanded to many more regions in terms of certainly controlling the epidemic of within the concentrated people who inject drugs. So it is now time for questions, and so we'd love you to pose your questions. If you could state your name and the media that you represent, and perhaps direct your question to a particular panelist or to the panelists at large, and I'll be happy to take those questions in the front. Thanks.
Michael Smith from the page today. One of the issues about HIV, HCV co-infection and the treatment thereof is that the clinical trials, which you presented yesterday after Rockstroh, are very positive. They're very good. The issue is, as with all clinical trials, how do you translate to the real life? And I'm wondering, there was a study, the last study yesterday presented by Dr. Swan of the Institute Pasteur, talked about sort of a real life experience with treating co-infection. And I wonder if perhaps you, Dr. Rockstroh, or anybody else can comment on that study and the caveats that you might have, or what you think of it.
Yeah, so I completely agree. I think that was also raised during the panel discussion. There is a need for also looking how are these trial results playing out in a larger real-world population, which is different per se because of the access issues we have in many countries, right? So whereas cirrhotics are excluded from some trials, that is your predominant patient population you're going to treat. Now, fortunately, though, we have a whole wealth of real-life data, and one example is the French sort of expanded access program they have, which was presented yesterday for the combination of cyclosporin and cladosphere. But there's similar cohorts in the US, there's similar cohorts in Germany, and throughout various parts of the world. I think the reassuring message here is that although the amount of cirrhotics in these patient populations almost is around 70%, whereas in the clinical trials it's around 15 to 20% max, the overall cure rates are really not that different. There's on average potentially a maximum 10% lower response rate, but that would then amount up to 85%. So I think we're still dramatically better than we were in the past. I think, though, that does pose a question, namely, if it's 85%, there are 15% left. So first of all, what we do with regard to retreatment of these patients, and what can we do to secure that this number actually goes up? So what can we learn around, is it adherence issues? Do we need resistance testing in some patients? And really, if you look at all the data together, we find out that treatment-experienced patients with cirrhosis, that is the tough group, and patients with genotype 3, those are the two, I would say, major patient groups we have to think about. And I think one of the clear recommendations currently is that patients with cirrhosis and previous treatment failure are treated longer, if you treat for 24 weeks plus antibiotic, because a lot of these patients can be risky. So I think we're also learning, and they're clearly helping to better understand how we can improve the overall implementation of care. But I think it's fair enough to say that there's no signal so far that the great response rates we see in very controlled clinical trials, and very, immune-wise, great CD4 count, low response rate, that doesn't translate into the real world. I think that's really not what we're seeing. We really see similar success rates.
Sure. Let me ask Anchalee and then
Yeah, can I have a question? So majority of the study focus on the genotype 1 and in developed country mainly. But how about the genotype 3 and genotype 6, which is quite common in Thailand, in Southeast Asia, like Vietnam or Laos, something like that. So I don't know how we can expand the research or the treatment to this area who in need. And then we look at our patients. Majority of them have severe liver disease. I mean, for the co-infection, it's about 80% of them have advanced liver disease. So how we can move the drug to the area in need. And also, we have a system for the low-income country. But how about the system of pricing in middle-income country we are facing right now?
Thanks, Anchalee, for the clinician's perspective, maybe Marina.
I think the other thing that we presented yesterday was an analysis that looked at how patients who are included into clinical trials are not at all representative of the vast majority of people who are co-infected, at least in Canada, so that only about 6% of our cohort participants would have been eligible to participate in any of the clinical trials. And the major reasons for exclusion are twofold. Principally, antiretroviral regimens that do not interact well with the drug-drug regimens. These are something that are potentially surmountable by changing HIV regimens, but it does say that it complicates the care to some extent. But even if you take that into account, it's only about 75% of people would not have been eligible for trials. And the major reason for that was active injection drug use or active drug use. And the reason we get concerned about that when you translate this to the real world is that situations where adherence might be an issue. We know that injection drug users actually do quite well on treatment, so there's no reason to deny treatment to people who are injecting. But we should be thinking about supports in order to permit them to maintain maximum adherence during the course of treatment, because clearly response rates are very much linked to taking almost every single pill, and avoiding resistance developing. So I think this is an issue that needs to be addressed.
Tracy, do you want to add something? Is it around the access piece?
It's both clinical and access. I think one of the things that was really amazing in some of the clinical trials that cure rates were just as high, if not a little higher, in co-infected people than in people with HCV alone, which to me speaks to the incredible structure that there has existed to deliver care and to educate and support people around adherence, and most people attribute the difference to really good adherence. As far as access, Dr. Anchalee brought up something incredibly important. I think when people hear middle income, it gets conflated somehow with middle class. But we're talking about an area which is partly seen as a huge emerging market for the pharmaceutical industry, but really it's where 73% of the world's poorest people live, and these are people who live on less than US at $1.25 a day. So if their government cannot provide hepatitis C treatment, they're not going to be able to pay for this out of pocket, neither the treatment nor the diagnostics. So we really have to use all the strategies that we used in HIV to make sure that people get access to these life-saving treatments.
Thanks, beautifully said, Tracy. Are there other questions, Fred?
Fred Scheich with IFR TV in Portland, Oregon, and I address this to either Tracy or Anchalee or anyone for that matter. It is, I think we're realizing the biggest problem here may be access. And how would this play out over the years with the discounts, with patient assistance programs, countries maybe holding up access to treatment for special populations within the countries? I mean, it seems like this is a drama that is really unbelievable in not accessing, being able to access something that is a cure. It's just beyond belief. How, with new drugs that are coming down the pipeline, will there be an effort to make a much more realistic approach at trying to establish a price that's within reasonable limits? How will that play out in the future?
Who would like to? Do you want to tackle that? Thanks, Tracy.
Well, some countries have really been leaders in this. For example, Egypt, while there's a very low rate of HIV, it has the highest hepatitis C prevalence in the world, and they have generic local production, and treatment there now costs less than $300, not per bottle, but per treatment course, because the government is absolutely committed, and there's other countries. Georgia has an elimination program. So some countries are really showing quite a bit of leadership on this. And that's partly due to their prevalence, it's partly due to the work of civil society, it's partly due to the work of doctors. Just like with HIV, it's a combination effort. But I think the thing that's helped the most is Andrew Hill and colleagues have published a couple of papers on what it costs to produce these drugs. And it's based on a volume of 5 million. It's not development, it's production. But still, when you hear that someone could get a 12-week course of drugs for $100, it really makes you think about all the ways that we could look at price reduction that keep a generic drug industry sustainable. And that's absolutely what has to happen. And these patient assistance programs, at least in the United States, between the restrictions and the programs, people are just getting lost. And we would never tell someone, come back for treatment when you have AIDS, because it's going to cost too much now to treat you. So we need to be able to not say that to people with hepatitis C. I can't imagine what it must feel like. I mean, I hear from people all they see is the coverage of how expensive the drugs are, and what they say is, I guess I'm just not worth it. And that is not what all of us have been fighting for at all. We want people to know that they're worth it.
Thank you for that. Another question.
Well, can I just add one thing? I think it's really crucially dependent that there is a political will in the respective country. There are many different ways of how you can sort of implement a program, and that's what I've learned, because we had, prior to the main conference, there was a co-infection workshop preceding the IS conference, really which brought together stakeholders of all the different areas and discussing how we moved ahead. We had the same conference in Melbourne, and really trying to see how these programs have been implemented. And I think it was very interesting to see, particularly the Brazilian presentation, because I think it's easier when you're in a country which you're classified as no income, and then there are attempts, and there are now 11 generic companies, and there are a lot of things happening. But for those where, let's say, the price is relatively high compared to what they really have as an income, it's going to be, I think, a real challenge. And Brazil would be one of those examples. And the amazing thing is that they sort of negotiated and strongly put pressure on companies to come with a price which was realistic, but then the price was dramatically reduced, at least in comparison to the German price, let's put it that way. But it comes up then, the revenue for the pharma companies comes basically over the volume of prescriptions. So they're basically saying, we're going to guarantee a treatment of so many thousand patients, but that obviously means they're going to have a tremendous amount of patients being put on therapy. And I think that's a great way forward. So you have to sort of also see that some countries are thinking much more creatively than others. So rather than saying we're going to ignore it all, we don't have harm reduction, everyone who takes IV drugs should go to prison, and if it's not infected, gets infected there. There's also the approach of thinking creatively, how can we do that, even in a system where the financial situation may be different than in Germany, right? So it's really quite I would say at least also positive to see that there are countries, which come from a very difficult economic point and are still able to implement programs, like Georgia or Mongolia or other countries, and then there are some countries who completely ignore the problem. So I think that's sort of the balance in which we are. The only hope is that sort of advocacy which builds around successful programs leads to getting other civil societies and people motivated, because also in Georgia it was not that everyone said let's do it. It was people marching on the street and demanding their right to health care, basically. So I think that's something which has to bring everyone back together, and I think that's where I see the role also of IS, because with the experience of HIV, this is the forum where people have learned to talk about these things and bring people together, and that is sort of an attempt which we could also facilitate and try to help.
Indeed, I'm having a deja vu to 3 by 5, and I'm sure many will remember that. Please.
Just to clarify, could you give me a ballpark idea of what is a 12-week course for most patients, except maybe the treatment-resistant cirrhotic patients, which need 24 weeks? But what does it cost for 12 weeks of treatment?
Yeah, so in Europe it really varies between 20 and 67,000 euro.
That's preposterous.
In Canada, the list price is at around 50,000 to 80,000 Canadian dollars. Each province enters into negotiations with a pharmaceutical company that we don't know about, so the actual price is something lower than that, probably in the range of 30,000, but it's still, it's the most expensive antiviral ever developed. This is an antiviral. It's not, we use antivirals for herpes that cost pennies and dollars a day. So.
But you have to remember that peg interferon viral for 48 weeks was also very costly treatment, and first treatment with receptor telomerase viral is more expensive than so. Hepatitis C therapy is always.
I'll maybe ask this part, but just the whole concept of reinfection, I actually never thought about that. So just to clarify, patients who achieve a sustained, sustained
response.
Of 95%. If they still inject drugs, they could get reinfected again?
Yeah, unlike many infectious diseases, there's no lifelong immunity after you've acquired and cured this infection. So anyone who's actually cured the infection either on their own, which occurs in about up to 20% of people, or who are cured through therapy are at risk for being reinfected if they're re-exposed. So anyone who continues to engage in behaviors that will put them at risk, and that's using and sharing unclean needles, or in the case of men having sex with men who acquire this sexually, there's a very high rates of reinfection in certain communities. Harm reduction will reduce that in the setting of injection drug use to virtually nothing. We're going to look at those rates, but we do see even in clinical trials, and several of those were presented yesterday, in every clinical trial, a relatively small numbers of people included in the trial, there's been at least 2 to 4 reinfections in every trial over a very short period of time. Yeah.
Just to clarify again though, so hepatitis C can be transmitted sexually as well as hepatitis B?
Yes, it's much less efficient to be transmitted sexually. We see principally the only group who has a very high rate of sexual transmission are HIV positive men who have sex with men.
Yeah, so that's important to clearly define, because otherwise it's confusing. Because when you think of sexual transmission, you think, does that mean that a discordant heterosexual couple has a high risk of getting hepatitis C, for example? And that's actually not the case. So it is really a traumatic sex practice rather than sexual contact. So that means you have to have a sex contact which has a very high likelihood of involving blood-blood contact, which could be unprotected anal sex, or could be fisting, or other practices. So it's really a traumatic sexual practice with a high risk of blood-blood contact. But I think it's also important to know that in that epidemic or outbreak of acute hepatitis C among MSM with HIV, there is a high percentage now of people, at least a third, who use also drugs in sexual context. So in beating someone up, they do something which is called slamming, and commonly use amphetamines which are injected and the needle is shared. So there is also a risk of needle sharing and intravenous drug use in that setting, which makes it a little bit more complicated, because the MSM with HIV does not consider himself as an IV drug user when he uses drug intravenously during sexual contact. And as such, I think that's all about finding new programs and messaging, because they just don't follow the same group. So that really means for us also that we have to re-educate and find programs and ways of reaching out and telling people that there is a remaining risk of reinfection if sexual behavior remains the same, and to see how can we reach people who don't really identify as IV drug users but are still intravenously using drugs in specific sexual settings.
I think reinfection is often used by payers as a rationale to withhold treatment, which is completely unacceptable. I think there's a big responsibility to make sure people have the information that they need to make decisions and have access to harm reduction. And instead of saying you can't be treated, look at it like a pond. If your pond is full of fish, you're more likely to catch one. But if someone has taken most of the fish out of the pond, you can go fishing, but your chance of catching one is much lower.
Just one point on that. I think one of the things that comes up from HIV, we've talked about treatment as prevention. I think that's the other aspect of this, is that there clearly now, and I think Natasha Martin showed that very nicely yesterday, evidence that if you treat those who are at risk of actually getting reinfected or infecting others early in their stage of liver disease, you actually reduce that pool, and so then the risk for the community drops significantly. And the way to actually get at eliminating this is to treat those who are likely to be transmitters, and that because we just remove it from the community, and then we can not worry about reinfection so much anymore.
So very much sort of the treatment as prevention.
Yeah. I mean, you need to see that demonstrated with data, but the modeling suggests that it's very powerful too.
Question over there.
Hi, and I apologize to everyone because I know I've been asking this question to a number of different panels, but I'm kind of still trying to get an answer on this. With men that have sex with men, especially involving catching hepatitis C through anal sex without protection, are you predicting, if there is no research, that hepatitis C numbers will go up with the use of PrEP?
Do you want to take that?
Yeah, I don't think the use of PrEP is going to change that, because PrEP has no impact on.
Well, I think what you're getting at is whether there's a changing in behaviors when more unprotected sex.
People aren't wearing condoms.
Right. So, I mean, I think it's debatable. The studies have suggested that does not occur, that there's not.
But I think the point is that in the studies, the amount of sexual transmitted diseases other than HIV, that people have is so high.
Yeah.
I mean, you can't have more than, in that short period in the Africa, they have a mean of 3 STDs. So it's not that risk behavior already exists with or without PrEP. And so PrEP is just helping at least to prevent the HIV part. It's not going to change the other part, but that part per se is at such a high rate, it's impossible that that will go up further. There were some hepatitis C infections in that study as well. So I think...
I guess the issue is that it's expanded more broadly, and people who formerly would have used condoms a lot start not using condoms.
I just know from what I've been told, being in New York City, I know a lot of people that are, men that have sex with men, that people are saying that when they meet a person, even on social networking and Grindr and all that stuff, they're saying, well, I'm positive, and they say, that's okay, I'm on PrEP. And it's almost like an invitation, like, we're going to have unprotected sex, it's fine.
So I think there are two aspects to this, and really we're in a bit of we're not in a totally data-free zone. We have seen in our clinical trials of PrEP that we've not seen condom migration or sexual disinhibition. These are the terms that are used to sort of describe the phenomenon that you are alluding to here. We have not seen evidence of that in the clinical trials or even in the demonstration project. However, it remains a theoretical risk, and many would say, well, those are not the real-world situation. So I do think we need to see how that plays out. Our sort of hypothesis at the moment is that this is a condom gap that PrEP is filling. That gap already existed, hence the very high incidence rates we are seeing pre-PrEP. So the individuals who are stepping forward for PrEP are the kinds of people who would have stepped forward for PEP, except people can't get themselves organized to get PEP. And so what we are now very much promoting, because we've seen fantastic evidence of reduction of incidence of HIV, is that people come to PrEP so that they are protected prior to their sexual encounters. That, time may tell that actually we begin to see some of this other, happening. Obviously, if indeed, as has already been suggested, these are individuals who would not have used condoms anyway, then all we're doing is making sure they're not going to be getting HIV. That does not address, therefore, the Hep C side of things. And that raises this question of will test and treat in the Hep C environment also have an impact in terms of bringing down rates, reducing the numbers of fish in the pool, etc. And so, I think this, hence, and to reiterate again, the International AIDS Society has taken this on because it's clear these two are very closely related. And our responses are very closely related in terms of the interactions that may happen. And I think we're going to have to keep an eye on it and see where we go.
I don't think that the incidence of acute hepatitis C is going to change. I think the bigger question for us from the treating side is, if we would have quick treatment available, which would be without side effects, could we then sort of, have a real change in the size of those who are infected and have less transmission? And the problem is that currently for treatment of acute hepatitis C, which is the first 6 months, where you sort of have to wait until someone does you spontaneously cured, yes or no, then you have a lot of time to infect people, and you're very highly viremic during these initial phases. Everything is like HIV, really. And so that the biggest risk of transmission is probably during that very acute phase of infection. And the question is, because people see their HIV doctor regularly get tested, we really pick up these acute hepatitis. I don't think we miss a lot, at least not in the HIV positive ones. And the question is, we would have a better intervention at that time. The problem is that only pegylated interferon ribavirin is currently available. Now, obviously, no one wants that pegylated interferon anymore. Plus, if you don't respond very well and you're not negative at week 4, you can treat for 1 year. So it's even easier to start treating with oral DAs once you're chronic and you're still earlier finished than if you treat with interferon due to the acute phase. And that has really brought down the number of people who are treated during acute hepatitis C. So if we see more infections now, I think that will just reflect that less people are really undergoing treatment at this point. And we have been really fighting for a really, really long time to get clinical trials with oral DAs into that patient population. And it's been a real struggle. But finally, there are now 3 trials. And I would expect that at CORE next year, you're going to see 3 trials being presented. And then the question is, does it work or not, or do we need to amend it? Could that lead to a larger study and address those needs? And I know that there are also registrational intents. And so eventually we might have a licensed oral DA therapy for intervening at acute hepatitis C, and I think that could really be very nicely followed up to see whether that has an impact on the transmissions.
Yeah, this is really important. I mean, one thing about the scenario you described, it's a bit of a wild card. The person who said he was HIV positive could have been on suppressive therapy and then would be much, much less likely to transmit. So I wonder if we are able to really provide treatment to people with acute hepatitis C. These drugs just drop the viral load so dramatically and so quickly, it's possible that even while someone's on treatment, before they finish it, that they'd be much, much less likely to transmit hepatitis C during the acute phase as well. And the other thing is, some of this is what I think of as a microculture. Like, not every HIV positive man who has sex with other men is sort of involved with this cluster of risk behaviors. There's biologicals, culture. It's an interaction of many, many things. So I think if you consider that, it'll be very interesting to follow the epidemiology in the next couple of years and see how things move.
Great.
Thank you very much.
Any other questions that we can field?
Can we come back to the access to care? I think for developing countries, not just the cost only, but and the cost and awareness and training, but the other things that the Hep C virus is different from HIV, and it's deal with the virus from infectious disease doctor, and also the liver from hepatologist. So this is another issue in terms of implementation between among the infectious disease and also the hepatologists. I don't know around the world was in Thailand still challenging on that. And also the political view of the government, and majority of the country, they don't have the stakeholder in charge for hepatitis. For example, in Thailand, we have division of AIDS, but we don't have division of hepatitis. So everything to move to the implement is quite slow compared to HIV, actually.
So I think what you're hearing and what we're hoping will begin to transpire is that the many lessons we've learned over 30 years in the HIV arena will really work through, percolate, if you like, into the world of Hep C, particularly at this very exciting time where really 1996, when we discovered highly active antiretroviral therapy, and it unleashed a mushrooming, now 15 million people accessing this treatment, has completely revolutionized how we think about HIV. We have a big job to do on the HIV side, but I think there are many lessons that can translate across. So we look forward to, in the next few years, seeing how this comes together. So really, at the end of our press conference, I'd like to thank a terrific panel who have been incredibly responsive and I think have really laid out the issues at hand. Thank you for some excellent questions, and wish you all well and safe journeys home.